This is JAPI and welcome to JAPI Podcasts.
I am Dr. Girish Mathur. Welcome to the JAPI Podcast of the September 2024 issue of JAPI, Volume 72, Issue 9. This issue of JAPI has some really interesting articles, including 10 original articles, 2 review articles, and also 1 consensus statement. There are also 3 unique case reports, 1 point of view, 1 pictorial CME, and 2 letters of correspondences. Let us discuss these in detail. The first original article is titled Importance of Dyslipidemias in Very Premature Coronary Artery Disease in India. It's a registry-based study by Aradhai Bana et al. Premature coronary artery disease is an important cause of death in India. This registry included 627 consecutive patients admitted for percutaneous coronary intervention from October 2020 to June 2021. The patients were classified into 3 groups. Group 1 with very premature CAD of less than 40 years of age. Group 2 with premature CAD of 40 to 59 years of age. And Group 3 non-premature CAD above 60 years of age. Major risk factors were determined and intergroup comparison was performed. The results were as follows. A total of 627 patients were enrolled, men 541, women 86. Group 1 had 79, that is 12.4% of the patients. Group 2nd had 422 patients and Group 3rd had 128 patients. Risk factors evaluated included age, sex, history of smoking or tobacco use, hypertension, diabetes, dyslipidemia, physical activity, BMI and family history of IHD. Majority of patients in Group 1 had single vessel disease, whereas majority of patients in Group 2 had double or triple vessel disease. Group 3 had a nearly equal distribution of coronary artery disease severity. Interestingly, Group 1 patient had presentation of STEMI in 51% of cases and non-STEMI in 46% of cases. Nearly 3/4 of patients had very premature or premature coronary artery disease, and the important coronary risk factors in this group are a family history of CAD, tobacco use and dyslipidemias. They had raised total cholesterol, raised LDL and non-SDL and VLDL cholesterol and triglycerides. The next article is titled A Study of 32 Adult Patients of Japanese Encephalitis in Jharkhand. It is by Yuvraj Lahare et al. Japanese encephalitis is a fatal endemic viral encephalitis common in India. It has a mortality rate of around 20 to 30% and most of the survivors are left with neurological deficits. Studies related to Japanese encephalitis in India so far had been mainly focused on the pediatric population. Hence, this study was taken up to evaluate the presentations and prognosis of Japanese encephalitis among adults. In this observational prospective study, 116 patients aged 18 years or above with features of encephalitis were investigated. Japanese encephalitis was confirmed in 32 adults by detection of IgM antibody in CSF through the National Institute of Virology Pune kit. Detailed demographic profile, clinical picture, fertility rate and prognosis were evaluated. Out of the 32 patients enrolled for the study, 75% were male and the mean age of presentation was 29.81 plus minus 14.14. Most of the patients belong to rural areas and presented between August and November. The most common symptom was fever seen in all patients, followed by altered sensorium in 75% of patients, seizure in 31.25% of patients, and headache in 25% of patients. Around 14 patients succumbed to death, and out of all patients who were discharged, 88.88% had neurological deficit and 11.11% of patients were healthy. The most common neurological deficit among discharged patients was an inability to speak. To conclude, we can say that high mortality and residual neurological deficits among adults were documented in this study. Detailed epidemiological surveys, awareness programs, and targeted use of vaccination can be helpful to prevent these grave sequelae. The next original article is titled Thyroid Profile in Liver Cirrhosis Patients, Correlation with Disease Severity and Recommendations for Clinical Practice. It's a cross-sectional observational study by Sagar Prakash Sangole et al. This study included 89 patients aged 12 years and above, admitted to medicine wards with ultrasound diagnosed liver cirrhosis, excluding pregnant women and those on thyroid altering medications. The findings revealed a male to female ratio of 4.23:1, with the majority of patients falling within the 40 to 60 age groups, averaging 46.9 years. Notably, 87.6% of patients exhibited thyroid abnormalities, primarily low FT3 syndrome and subclinical hypothyroidism. Classifying patients according to child PUG score, 2.2% for CP class A, 22.5% for CP class B, and the remaining 75.3% were CP class C. Across all CP classes, low FT3 syndrome was prevalent, particularly in CP class C. Correlations between thyroid hormone level and liver disease severity assessed via CP and model for end-stage liver disease scoring system were observed. Specifically, FT3 levels demonstrated a negative correlation with liver disease severity, while no significant correlation were found for free T4 and thyroid stimulating hormone levels. Based on the findings, the authors recommend routine thyroid function testing for all liver cirrhosis patients, irrespective of disease severity, to facilitate early detection and intervention. The limitations include a small sample size and a precision error of 10% due to resource constraints for thyroid function testing. Moreover, reliance solely on ultrasound for liver cirrhosis diagnosis may lead to misdiagnosis, highlighting the need for complementary non-invasive tests such as fibroscan and SGPT score. Next original article is a comparative analysis of heart rate variability indices in patients with liver cirrhosis by C.L. Naval et al. Autonomic disorder in cirrhosis is seen in both alcoholic and non-alcoholic cirrhosis. Autonomic disorder in patients with cirrhosis was evaluated with a standard autonomic function test, heart rate variability, and 123 iodobenzyl gluidine myocardial scintigraphy. Studies have shown that 40 to 47% of cirrhosis patients may have parasympathetic dysfunction and rest may have both sympathetic and parasympathetic dysfunction and leading to heart rate variability to sudden cardiac death. This is a hospital-based cross-sectional study involving 150 patients with cirrhosis and 110 healthy age-matched controls. After detailed history, examination and investigations, autonomic dysfunction tests included HRV, statistical analysis of HRV indices and correlation with observed outcome were done. Results showed that heart rate variability indices such as SDNN, PNN 50%, HF, LF and the LF-HF ratio were found to be significantly lower in patients with CLD compared to the healthy control group. The severity of CLD was measured by the Child-Pugh score, with 52% of patients having a CP score class C, 30% having a CP score class B, and 18% having a CP score class A. The CP score in CLD patient showed a statistically significant negative correlation with various HRV indices. The study concluded that liver cirrhosis patients have reduced HRV compared to healthy individuals. A decrease in HRV highlights people at risk of death. This is a variable that can be used to track patients over time and aid in transplant selection. The next original article is titled A Study of Cardiac Autonomic Neuropathy in Patients with Diabetes Mellitus by Shivam Mirg et al. Background for the study is atherosclerotic coronary artery disease, diabetic cardiomyopathy, and cardiac autonomic neuropathy are the three categories into which the cardiovascular consequences of diabetes can be grouped. After all other potential causes have been ruled out, cardiovascular autonomic neuropathy, often referred to as the CAN, in the literature is defined as the impairment of autonomic regulation of the cardiovascular system. This was a prospective observational study comprising 60 patients and was carried out in a tertiary care hospital for a total duration of 18 months. The presence of CAN was assessed with the help of Ewing's battery composed of 5 bedside tests. The data obtained was analyzed using appropriate statistical tests, and results thus obtained were compared with various national and international studies. It was thus concluded by the authors that cardiac autonomic neuropathy is a frequently overlooked microvascular complication of diabetes mellitus, with the current study indicating a prevalence of 88.3%. The findings suggested a predominant parasympathetic over sympathetic nervous system involvement in diabetic autonomic neuropathy, as demonstrated by various diagnostic tests. Among these, the abnormal expiration to inspiration ratio observed in 75% of patients emerged as the most prevalent indicator of parasympathetic dysfunction. Key determinants of CAN include the duration of diabetes, patient age, and the presence of other microvascular complications. The study also highlighted the clinical utility of QTc interval prolongation on ECG, which, despite its high specificity of diagnosing CAN and assessing its severity, generally exhibits low sensitivity. Authors also suggested that as there was significant association of CAN with increased mortality, it is imperative that all diabetic patients be screened for CAN at diagnosis and subsequently on an annual basis, in alignment with the recommendations from the ADA. Early intervention through optimal glycemic control and lifestyle modification can play a crucial role in preventing the development of CAN. The next original article is titled Improved Clinical Outcomes with the Combination Therapy of GLP-1 receptor agonist and SGLT2 inhibitor in overweight obese people with type 2 diabetes. It's a real-world evidence from the Indian subcontinent by Anant Nigam et al. This study aimed at assessing the clinical impact of the combination therapy of a GLP-1 receptor agonist and SGLT2 inhibitors in overweight obese patients with suboptimal glucose control from the Indian subcontinent. Methodology: it was a retrospective observational study of 2 real-world evidence. They retrospectively observed the effect of the combination therapy of GLP-1 RA, injection dulaglutide 1.5 mg per week, and SGLT2 inhibitor canagliflozin 100 mg per day at weeks 16, 32 and 52 on HbA1c, body weight, systolic blood pressure, lipids, change in dose of antidiabetic agents and antihypertensive agents. As regard to results, a total of 95 type 2 diabetes patients were studied in 2 real-world evidence study. In real-world 1, 40 patients completed the study with a mean age of 49.4 years, with weight 92.6 kg, BMI 30.6, with duration of type 2 diabetes averaging at 8.1 years. At week 32, the mean reduction in A1C was 1.3 and the mean weight loss was 5.5 kg. This group was then followed up until 52 weeks in real world evidence 2 patients with age 51 years, the average weight 92.6 kg, BMI 31.1 and with 8.4 years duration of diabetes met the inclusion criteria. In both the real world evidence study, durable reduction in A1C of 1.3 to 1.4% was observed when patients received dual therapy with GLP-1 RA and SGLT2 inhibitors. There was also significant weight loss. The durability of this weight loss was observed even at week 52. A significant reduction in doses of sulfonylurea and basal insulin in sizable number of patients was also observed. Conclusion of the study: a statistically significant improvement in glycemic control, weight and improvement in CV risk factor was observed with the GLP-1 receptor agonist and SGLT2 inhibitors combination, which was well tolerated in real world scenario. Limitation of the study: it was a retrospective observational study with small sample size and therefore any information not entered due to real world evidence scenario could not be confirmed or recollected. Also, author accepted their inability to measure waist circumference, which could have been an indirect measurement of visceral adiposity. The next original article is titled Clinical Significance of Platelet Indices, that is mean platelet volume and mean platelet volume to lymphocyte ratio in acute coronary syndrome. It's a hospital-based observational study by Subabrata Biswal et al. To give a background of these platelet parameters, mean platelet volume, a parameter indicating platelet size, is positively correlated with platelet activity. Increased mean platelet volume, indicative of more reactive platelets, has been associated with atherombolism and myocardial damage in acute coronary syndrome. Simple and routine tests like mean platelet volume have the potential to aid in the early prediction of the risk of acute coronary syndrome in acute care medical facilities. Mean platelet volume has emerged as a robust and independent predictor of impaired reperfusion and 6-month mortality, not only in ST elevation MI but also in non-ST elevation MI. The mean platelet volume to lymphocyte ratio represents another novel marker implicated in the diagnosis and prognosis of acute coronary syndrome. There are very few studies investigating its association with acute coronary syndrome patients. This hospital-based case control observational study was conducted from 2020 to 2022 and included 110 patients of ACS and an equal number of age and sex-matched controls with chest pain of non-cardiac origin and primarily compared mean platelet volume and mean platelet volume to lymphocyte ratio in ACS patients and controls. The secondary objective of this study was to observe the association between mean platelet volume to lymphocyte ratio, and different SES types, as well as their correlation with the global registry of acute coronary events risk score and in hospital major adverse cardiovascular events. Results were higher mean platelet volume and mean platelet volume lymphocyte ratio were observed in SES cases compared to controls. Significant associations were found between platelet indices and various acute coronary syndrome. Both indices positively correlated with the severity of heart failure, Grace score, and in-hospital MACE. Mean platelet volume to lymphocytic ratio showed a positive correlation with the duration of hospital stay, but mean platelet volume did not. Mean platelet volume serves as a more effective prognostic marker than mean platelet volume to lymphocytic ratio in predicting in-hospital mortality. To conclude, we can say that both mean platelet volume and mean platelet volume lymphocytic ratio are higher in SES than in healthy individuals. Therefore, both may be used as discriminating markers for differentiating cardiac and non-cardiac chest pain when cardiac biomarkers are not available. Additionally, both have good sensitivity for predicting the severity of the disease, in-hospital mortality, and MACE in SES. Limitations of this study is its relatively small sample size, and hence it limits its generalization to wider population. Therefore, a larger study is warranted before implementing these findings in clinical setting. Confounding factors such as diabetes, obesity, medications which can influence platelet size are potentially leading to false positive results but not taken care of in this study. The next original article is titled Variability and Challenges in Pulmonary Rehabilitation Practices Across India, Insights from a Nationwide Survey by Maria Prakash Jindani et al. The study employed a cross-sectional survey designed to collect data from Indian cardiopulmonary physiotherapists with at least 2 years experience from October 2021 to November 2022. The survey instrument was a structured questionnaire which was distributed through social media platforms such as WhatsApp, Facebook, Gmail, covering demographics, structure, process, and outcome quality indicators. Significant variability in pulmonary rehabilitation practices were observed primarily in urban areas. Key challenges including limited awareness, accessibility issues, inadequate interdisciplinary teamwork, and lack of standardization. The survey highlights the need for a standard pulmonary rehabilitation protocol and national guidelines to improve pulmonary rehabilitation services consistency and quality in India. Emphasizing multidisciplinary teams, regular audits, and comprehensive data collection can enhance PR delivery and outcomes. The next original article is titled A Study of Urinary Electrolyte and Fractional Excretion of Uric Acid in Evaluating Hyponatremia by Kaushik Ghosh et al. New modalities like fractional excretion of sodium, urea, and uric acid have been introduced to differentiate between hypovolemic to euvolemic hyponatremia. This study was conducted to categorize hyponatremia based on volume status and differentiate between the SIADH group and non-SIADH group on the basis of fractional excretion of sodium, fractional excretion of uric acid, urine uric acid, and serum uric acid values. This study was intended to find out whether fractional excretion of uric acid is better than fractional excretion of sodium in the diagnosis of SIADH. This study included 61 random patients participants of more than 14 years of age with serum sodium with less than 135 on admission, with serum osmolality of no more than 280 millimole per liter. The patient's mean age was 55.46 years. The study included 54 males and 7 females. History of cirrhosis, fever, vomiting and diarrhea were there in 30 cases. Vomiting was seen in 15 cases, epidemiology in 3 cases, ascites and edema in 9 cases. Out of all these cases, 31 had SIADH and 30 had non-SIADH. Among the non-SIADH cases, 21 had hypovolemic hyponatremia and 9 had dilutional hyponatremia. Urinary osmolality was significantly lower in the non-SIADH group than in the SIADH group. Higher urine sodium was observed in SIADH group in comparison to non-SIADH group. Urine creatinine and urine creatinine to serum creatinine ratio were lower in SIADH group than in non-SIADH group. The non-SIADH group had considerably higher serum uric acid levels, but the SIADH group had higher uric acid levels. Compared to the non-SIADH group, the fractional excretion of urea, fractional excretion of sodium and fractional excretion of uric acid levels in the SIADH group was significantly higher. Calculation of the AUC for different parameters was done to compare diagnostic superiority. Compared to urine sodium, fractional excretion of sodium is better in diagnosing SIADH, and fractional excretion of sodium is also better than fractional excretion of urea in diagnosing SIADH. However, in the highest area under the curve was obtained for fractional excretion of uric acid. Therefore, fractional excretion of uric acid is the most superior parameter in diagnosing SIADH among the studied parameters. The study concluded that fractional excretion of uric acid outperformed fractional excretion of sodium in diagnosing SIADH, achieving a higher AUC of 0.984. Fractional excretion of uric acid had the highest specificity, that is 100%, and sensitivity, that is 96.77%, with an AUC of 100% for diagnosing SIADH at a cutoff value of more than 12%. Both fractional excretion of urea and urinary sodium showed similar diagnosing capabilities for SIADH, but they were less effective compared to fractional excretion of sodium or fractional excretion of uric acid. The next original article is titled Lipid Response to Statins plus Ezetimibe in Mumbai. It's a cross-sectional observational study by Shah VT et al. India has the highest burden of cardiovascular disease among developing nations. There has been a significant under-implementation of recommended aggressive lipid-lowering strategies for achieving LDL cholesterol goals. Moreover, ethnic variation in response to statin therapy has prompted clinicians to adopt lower doses of statin therapy in Asians to achieve comparable LDL cholesterol lowering. The main objective of this study is to document the dose of statin plus ezetimibe required to achieve the European Society of Cardiology goals of LDL cholesterol. This retrospective single-center cross-sectional observational study in Mumbai evaluated the dose of atorvastatin, rosuvastatin plus ezetimibe treatment at which patients with established atherosclerotic coronary vascular disease, irrespective of their baseline level, achieved LDL cholesterol goals. Those with LDL cholesterol with more than 55 mg per deciliter on current therapy were switched to a combination of rosuvastatin plus ezetimibe. The primary and secondary outcomes assess the impact of rosuvastatin 40 mg and ezetimibe 10 mg on LDL cholesterol and non-HDL cholesterol goals. At the end of follow-up, LDL cholesterol was observed to less than 55 mg per deciliter in 42.16% of patients with rosuvastatin 40 and in another 43.28% with combination of both the drug. A few patients, that is 14.6%, achieved this goal with other doses. Similarly, non-HDL cholesterol less than 85 mg per deciliter was observed in 39.3% patients with rosuvastatin 40 and in another 47.4% with the combination. Overall, around 20% of patients were unable to achieve their LDL cholesterol and non-HDL cholesterol goals despite being on high intensity statin plus ezetimibe therapy. In the first report of its kind in India, this study showed that suboptimal LDL cholesterol goal achievement occurred in around 20% of high-risk ASCVD patients on dual therapy. This indicates that clinicians should consider the addition of other therapies like bempedoic acid, PCSK9 inhibitors, and inclisiran to mitigate the residual risk. The next is a consensus statement about Indian consensus on the role and position of angiotensin receptor neprilysin inhibitors in the management of heart failure by Hriday Kumar Chopra et al. Despite the high rate of mortality associated with heart failure, most patients do not receive maximal guideline-directed medical therapy. ARNIs reduce cardiac morbidity and mortality in patients with heart failure with reduced ejection fraction. However, recent data indicated that only 4.8% of patients with heart failure with reduced ejection fraction receive ARNI in India. Hence, at a national consensus on heart failure meeting, cardiology experts from India formulated a national consensus on the use of ARNI in heart failure based on current evidence and guidelines. The consensus of the expert was as follows. ARNI should be used early in heart failure, particularly in de novo patients with heart failure with reduced ejection fraction and those with acute decompensated heart failure. Starting ARNI during the first hospitalization is preferable. Benefits of ARNI are seen across all doses. ARNI should be used in heart failure irrespective of the presence of low systolic blood pressure or diabetes. ARNI outperforms ACE inhibitors in lowering cardiac death, sudden cardiac death, and heart failure hospitalization in heart failure with reduced ejection fraction individuals and improves the quality of life. Patients with heart failure with reduced ejection fraction on RAS inhibitors should be switched to ARNI to reduce the risk of repeated hospitalization for heart failure, worsening of heart failure, and cardiac death, and to improve the quality of life. ARNIs can also be used for secondary benefits in patients with heart failure with preserved ejection fraction and heart failure with mildly reduced ejection fraction. ARNIs reduce progressive myocardial fibrosis and myocardial injury, thereby improving prognosis. The next review article is titled Polypharmacy and De-Prescription, Role of Internist by Gaurang Santra et al. This review article highlights the importance of why it is necessary to review the prescriptions in the elderly and what factors affect polypharmacy. Why it is necessary to reduce the number of unwanted or unimportant medicines from the prescription when there are polypills in the prescription. Polypharmacy is the concurrent use of 5 or more drugs per day. It is common in the geriatric population due to presence of many comorbid medical conditions. Therefore, the prevalence of polypharmacy is increasing as the number of old people is increasing worldwide. The clinical guidelines, recommendations and wider availability of preventive and curative medicines are important causes of polypharmacy. Appropriate polypharmacy is beneficial to the patients. However, polypharmacy may be inappropriate, causing adverse effect, drug interactions, poor treatment efficacy, hospitalization and high healthcare costs. Inappropriate polypharmacy can be prevented or managed by medication optimization through medication review, de-prescription, ensuring adherence and patient education. De-prescription includes the removal of risky, unnecessary and duplicate drugs, replacement with efficacious drugs, and relaxation of tight control as per life expectancy. Several de-prescription tools, both explicit and implicit, exist for helping physicians to decide when to de-prescribe or to add medicines, especially in old age. Care should be taken during de-prescription to prevent unjustified omission, reduction to subtherapeutic doses, and onset of withdrawal features. Age and disease-related changes in pharmacokinetics and pharmacodynamics of drugs should be considered during the optimization of pharmacotherapy. This article is an awakening call to all the physicians attending geriatric patients and compliments to the author for bringing out relevant points in the article which would benefit one and all. This was all about the articles published in September issue of JAPI. Thank you very much for listening to JAPI Podcast. Thank you.